Hello everyone, I am Dr. Rohan Khandelwal, your Marrow Surgery faculty, and we are going to talk about the surgery recall of the May INI-CET exam. Now, the exam was not a typical INI-CET exam. I would say that it was a tricky paper, and the students whom I spoke to said that it was of moderate difficulty, more difficult than the previous INI-CET exam. Another challenging part of this year's INI-CET paper was that previous year topics and direct repeats were much less than previous papers. So, usually in INI-CET you have more repeats, more direct repeats and more PYQ repeats. They were less this time, and certain subjects were very challenging and difficult. Another thing was the lack of time which students got because of multiple correct answer questions. The number of multiple correct answer questions were quite a lot. In surgery, if we talk about surgery was again moderate difficulty but an unusual paper. So, if you see the distribution, trauma, which is usually a high yield topic in INI-CET, there were only 2 questions from trauma. Breast and endocrine and GIT form the major bulk of the paper, around 8 to 9 questions from both of them, and 3 questions from vascular surgery as well, something which a lot of students usually neglect. So, in all there were around 22 to 23 questions which were asked from surgery, and from them I would say that 3 or 4 were really tricky, otherwise they were manageable if one had a good knowledge of the subject. Now, without wasting any time, let's start with the discussion. I am going to start with general surgery. Also, in the end of the video, I will share my thoughts regarding those who have appeared for INI-CET, how to prepare for future exams, how to go about it. I will discuss it towards the end of the video. So, the first question was feeding is done through the given method, which of the following is not a complication. So, they had shown an image of an IV of a central line and they had asked which is not a complication of TPN. We know through central line we give TPN, that is total parenteral nutrition. Now, if you look at the complications, pneumothorax we know is a complication, especially in the subclavian route. Maximum risk of pneumothorax is there, followed by IJV, right. So, pneumothorax we know is subclavian more than IJV. Refeeding syndrome is a major complication, and I will share the update regarding refeeding syndrome as well, and osteoporosis can also be there. So, aspiration is not a complication of TPN, aspiration is a complication of enteral nutrition. Enteral nutrition, which is given through the mouth or through a feeding gastrostomy or jejunostomy, aspiration can be a complication, and we know that aspiration rates are more in a gastrostomy as compared to a jejunostomy. Right, a feeding gastrostomy, there are higher rates of aspiration. These aspirations can also occur when the patient has a nasogastric tube or a Ryle's tube. These are the complications of total parenteral nutrition. We can divide them into central line related complications and feeding regime related complications. Central line pneumothorax, I have told you, subclavian more than IJV, arrhythmias, thrombosis, air embolism, migration, and catheter related sepsis is the most common central line problem in TPN. So, the patient on TPN, if the patient is running fever, we always suspect a central line related sepsis. We try to take a peripheral blood sample and a central line sample, do the culture for both. If not, we can put in an endoluminal brush and take a sample for culture, or the last resort is we remove the central line and we send the catheter tip for culture if required. The feeding regime complication, hypoglycemia, is the most common. There can be weight gain, and weight gain is the earliest sign of overfeeding. This is the earliest sign of overfeeding, and this is one thing which is monitored on a daily basis in a patient who is receiving TPN. Cholestasis can be there, micronutrient deficiency, zinc being the most common. So, this is a table from the latest Bailey which tells us about the monitoring of patients who are on feeding regimes, and you can see daily monitoring of vitals is required, body weight is required, intake output charting is required, type of food consumed is required. You initially do a daily serum electrolyte values and liver function tests, and then later on you can do once a week tests once the patient is settled. Weekly to fortnightly you need to do a complete blood count, plasma proteins, calcium, zinc, thiamine, vitamin B12, folic acid, and 3 to 6 monthly you need to do ferritin, vitamin D3, selenium and manganese. Like I said, initially electrolytes can be done on a daily basis, and then they can be shifted to a weekly basis once the patient is stable. This is another chart for refeeding syndrome. We know refeeding syndrome develops when we give increased amount of nutrition to a patient who's chronically malnourished. So a chronically malnourished patient, if we give a lot of nutrition, that can give rise to refeeding syndrome. So this is a table in the latest Bailey where they've highlighted who are at risk of developing refeeding syndrome. So one or more of the following, that is BMI less than 16, unintentional weight loss of more than 15% in 3 to 6 months, little or no nutritional intake for more than 10 days, and low potassium, phosphate, magnesium to start with before we start feeding. Or 2 or more of the following, that means BMI less than 18, weight loss more than 10% in 3 to 6 months, little or no nutritional intake for 5 days, and history of alcohol abuse or on insulin, chemotherapy or antacids. So these are the patients who are at risk of developing refeeding syndrome, and we should be careful. We should gradually increase the quantity in these patients. Now another thing in refeeding syndrome which is there is that the main process in refeeding syndrome is hypophosphatemia. This is the main driver of refeeding syndrome, and in addition to this you can get hypokalemia, hypophosphatemia, hypomagnesemia and hypocalcemia. These are the metabolic derangements which you can see, plus there is fluid overload. And all this gives rise to arrhythmias and congestive heart failure, which can be the cause of death in these patients. But the main driver, if you're asked, is hypophosphatemia. Now nutritional support in this group, we need to give maximum 10 kilocalories per kg per day, aiming to increase to full needs by 4 to 7 days. These are all lines from the latest Bailey. And for prevention, what should we do? For prevention, I've already told you, gradually increase quantity. You gradually increase quantity. We give thiamine supplementation and we monitor electrolytes. Strict monitoring of electrolytes and symptoms should be there. So this was regarding the first question. I've told you about refeeding syndrome because it's frequently asked in the exam as well. This is another thing which is a Bailey update, liver dysfunction on TPN. Long-term TPN use, 25% can have liver derangements. Most common is fatty liver, and it is more common in children, and it can be avoided by giving lipid-free solutions. Small number of patients can develop IFALD. What is the full form of IFALD? Intestinal failure associated liver disease, and they can develop fibrosis, and some of them later on might require transplants as well. So these are all Bailey updates which I wanted you to know. The next question is a 28-year-old lady who presented with 36 weeks of gestation, underwent a C-section, had placenta accreta and had profuse bleeding. She was transfused, massive blood transfusion was done. Which of the following is not seen in massive blood transfusion? Now first of all, you should know the definition of massive blood transfusion. So entire blood volume in 24 hours, entire blood volume in 24 hours, or you have more than 10 units in 24 hours, or you have more than 4 units in 1 hour. Okay. So more than 4 units in 1 hour. These are the 3 definitions of massive blood transfusion. Now massive blood transfusion, what are the complications which are there? So hypothermia can be there because we are giving blood quickly and there is not enough time to warm the blood or to get it to room temperature. Hypomagnesemia can be there, and this is mainly because of citrate toxicity. Citrate we know is the anticoagulant which is used, and because of citrate toxicity, hypomagnesemia can be there. Hypocalcemia is because the citrate chelates calcium. Citrate chelates calcium. Okay. Now, if you see Bailey, and I'll show you this table as well. This is the table from Bailey. If you see Bailey, they've given coagulopathy is the most common cause of death, hypocalcemia, hyperkalemia, hypokalemia, and hypothermia. And there is metabolic alkalosis. Right? So, Bailey writes that both hyper and hypo can develop. Now, what we had to choose here was we had to choose one, and if we had to choose one, the answer is going to be hypokalemia, because hyperkalemia is more common. Hyperkalemia is more common. That is why we are choosing hypokalemia. But if you go by Bailey, this is also not completely the wrong answer. Okay. So, why does hyperkalemia occur? Because in stored blood, RBCs lyse. And when RBCs lyse, the intracellular ions, that is potassium, they come out. And when you transfuse this blood, initially there is hyperkalemia, later on there can be hypokalemia as well. But if we have to choose one, hyper is more common than hypo, that is why we are marking hypo here. So, this was regarding massive blood transfusion. This is a mnemonic which Dr. Illa told me, that is CATCH. So, coagulation abnormality is most common, acidosis, alkalosis is more common, hypothermia, citrate toxicity, hyperkalemia and hypocalcemia. Also hypomagnesemia is there. There was one instrument which was asked, again not the typical instrument which you expect in the exam. This was a mixtures forceps, which is like a long curved forceps. Sometimes they can be right angles as well. So you can hold them to hold pedicles or to pass a thread. That is where mixtures is used. So this was mixtures. You know, a Rampli sponge holder, the other options, a Rampli sponge holder used for holding sponge to clean the part. This is an Adson's or a tooth forceps which we use to hold tough structures, and this was a Rampli sponge holder. The other one was a Cocker's forceps. You know, the Cocker's has teeth in it, and it is again used for holding tough structures. So, these were the questions from general surgery. Moving on to breast and endocrine, which formed almost 8 to 9 questions. So, smoking increases the risk of. So, this was like a googly from breast, right? There are so many other important topics to ask from, but they asked that smoking is a risk factor or increases the risk of which of the following breast problems. So, we know that duct ectasia, also known as Zuska's disease or periductal mastitis, smoking is a known risk factor. Mondor's disease, which is thrombophlebitis of the chest veins. This is thrombophlebitis, superficial thrombophlebitis of chest veins, and it appears like a cord-like swelling below the breast. This is also associated with smoking, and breast cancer is also associated. Fibroadenoma is not associated with smoking. So, A, C, D are the correct answers which you should know about. Mondor's disease, I told you, is a cord-like swelling below the breast. It takes a month and a half to 2 months for the cord to settle down, and the treatment is pain control and topical heparinoids. That is what is used for Mondor's disease. The next question was a straightforward question. Which of the following are done in breast conservation surgery? So, breast conservation surgery we've discussed is a lumpectomy, and nowadays we take a 1 millimeter margin, okay, 1 millimeter margin. In the latest Bailey, there is a printing error, they've given us it as 1 centimeter, 1 millimeter margin is being taken for breast cancers now. So, we do a wide local excision, that is correct. Axillary node dissection can be done. So, you can either do sentinel biopsy or you can do axillary clearance. Frozen can be done to see margins during breast conservation. Okay. Post-operative radiotherapy is optional. This is a wrong statement. We have discussed that all patients who are undergoing breast conservation need radiotherapy. You have to give radiotherapy. There is one exception which has come out of late, and that is somebody who is more than 70 to 75 years of age, low risk cancer, there we can avoid. But for your exams, I want you to remember all patients getting breast conservation need radiotherapy. So, 1, 2, 3 are correct statements in this question. So which of the following are correct statements about BRCA1 gene, right? Again, BRCA1 and 2 have been asked many times in the exam. So this you can say was a previous year topic, right? We always say that topics get repeated, maybe questions might not. So you should know about BRCA1 and 2. Another question which they've asked frequently is the indications. When do we get BRCA testing done? And I'll cover that up as well. So BRCA, correct statement, it is useful for DNA repair, that is correct. Risk of development of ovarian cancer is there in both BRCA1 and 2. It is a tumor suppressor gene, so A, B, C are correct. D, mutation is seen in a subset of Fanconi's anemia. This is wrong. Fanconi's anemia can be associated with BRCA2 mutation, not with 1 mutation. So this you should remember, Fanconi's anemia can be with BRCA2, not 1. So this is the table which I wanted you to know. What are the indications to do BRCA testing? Now for all patients, any blood relative with a BRCA mutation, you need to test them as well. So like Angelina Jolie's mother and aunt had BRCA mutation, so she was also offered the same thing. A personal history of ovarian, fallopian tube or primary peritoneal cancer. Patients with breast cancers, if one or more relatives have been diagnosed less than 45. Personal history of bilateral breast cancer, male breast cancer or triple negative breast cancer less than 60 years, you should do testing as well. Without a family history of breast and ovarian cancer, if you have more than two first, second or third degree relatives, at least one who's been diagnosed with breast cancer less than equal to 50 years, then also BRCA testing should be offered. So BRCA is an important topic from the point of view of INI-CET. Another straightforward question, which of the following is not an advantage of ultrasound breast over mammography? Okay, so we know that mammographies are not useful in young patients who have dense breasts, and I've told you less than 40 years we prefer an ultrasound, more than 40 years we prefer a mammogram, right? So in young patients with dense breast tissue, mammography is not sensitive, ultrasound is sensitive, so this is correct. It differentiates solid versus cystic lesions, that is a very big advantage to have. Guided biopsies, I do most of my biopsies under ultrasound guidance. I have it in my OPD chamber and we do ultrasound guided biopsies. Can be used for mammographically undetectable, clinically non-palpable breast mass. Out of the 4 statements, this is the wrong statement. Now I have discussed this with a lot of breast radiologists. If this is the statement, I would like to tell you that there are certain lesions like ductal papillomas. Ductal papillomas are usually not palpable. We know patient comes with bloody nipple discharge. So they are non-palpable and they are not picked up on mammogram, but they can be detected on ultrasound, right? But that is a one-off situation. We have to choose one statement, then this is the correct answer. Also, there is some ambiguity in this recall. Some students were saying mammographically palpable clinically, mammographically undetected but clinically palpable breast lesion, okay, or something of that sort. So this last statement does not make sense, which is why it is the wrong answer. The top 3 statements are clear advantages of ultrasound over mammography. So these are definite advantages of ultrasound over mammography. So these are the latest position statements of the American Society of Breast Surgeons on mammography. So screening mammography should be started at 40 years of age for ladies with average risk of breast cancer. Women with higher than average risk should undergo yearly screening mammography and should be offered supplemental imaging. This should be risk based. Okay. What is the risk based? I'll tell you. So women with average risk, I've told you we start at 40 years, we do annual mammogram. But women with higher than average risk, you can see here, those who have hereditary susceptibility from gene status. So those who are supposing BRCA mutated, or those who have had prior radiation to the chest wall between 10 to 30 years. Here we are going to start with annual MRI starting at 25, and then we will shift to 3D mammography at 30. Those who have more than 20% predicted lifetime risk of breast cancer on various scores, these scores are like Gale model or BRCA Pro score, or those who have a strong family history, we will do 3D mammography starting at 35, or we can do MRI starting at 35 years of age. So these are the high risk groups, and you should remember 25 and 35 years, 25 for BRCA and chest wall radiation, and for others it starts at 35. This was another straightforward question. Which of the following drugs is used in patients with metastatic HER2/neu positive breast cancer which is resistant to trastuzumab? So we know trastuzumab is the first line agent. Anyone who's HER2/neu positive is going to be given trastuzumab, or Herceptin. Now there is a new agent which has come up along with trastuzumab or Herceptin. Usually we are clubbing it with pertuzumab. Clubbing it with pertuzumab or Perjeta, right? So this is pertuzumab or Perjeta. Okay. Now if there is resistance to them, if there is resistance to these drugs, then the other options which we have are TDM1. TDM1 is another HER2/neu agent which can be used, or we have lapatinib. Now lapatinib is given orally, and lapatinib can also have effect on brain metastasis in patients who are HER2/neu positive. So the correct answer here is going to be lapatinib. Now this is a question which some students were saying it came and some are saying it did not come. I am covering it irrespective. They had given two columns and you have to match the following columns, and they had said that if there is a thyroid swelling, which is pressing on these structures, how will the patient present? So if it presses on the esophagus, I think so this is very easy, dysphagia. If it presses on trachea, there is dyspnea. Recurrent laryngeal nerve is going to be hoarseness, and sympathetic change is going to be Horner's syndrome. You know, ptosis, meiosis, anophthalmosis and hydrosis. So this was pretty straightforward. If this question came, I think so it was a very simple question which was asked. So mediastinal masses and especially thymomas are a favorite of INI-CET exam, and again there was a question from thymomas. Which of the following statements is true? Most common posterior mediastinal tumor, this is false. It is the most common anterior mediastinal tumor, and it is most common overall as well. It is most common overall as well. It is the most common neoplasm of thymus, this is correct. Patients are usually symptomatic with dyspnea, dysphagia, SVC syndrome. This is false. Usually these patients are associated with myasthenia gravis. They can be asymptomatic as well. Chest X-ray is the investigation of choice. This is also false. We do a CECT, that is the investigation of choice in these patients. So CECT, thorax, neck and thorax, it will be the investigation of choice in a thymoma. So this is from Bailey. Thymoma is the most common mediastinal tumor, accounting for 25% of all mediastinal tumors. They can vary from benign to aggressive, and Masoka classification, this term has been asked. Masoka classification is used for thymomas. This has been asked in many exams. As I said, they are associated with myasthenia gravis, a neuromuscular condition, and they respond to excision of thymus. We've also discussed that if there is a patient who has an inferior parathyroid adenoma, that it is worthwhile doing a thymectomy in those patients as well. So these are the points which you should know, and thymectomy can be done either by median sternotomy, or if thymoma is small, then it can be excised using a minimally invasive approach, that is VATS. VATS stands for video assisted thoracoscopic surgery. So these are directly from Bailey which you should know. This is another chart which I have covered in the notes. I have covered it in the thorax module. I have told you mediastinal tumors are usually asked. Anterior mediastinum, you have thymoma, lymphoma and germ cell tumor. This you can remember as 3 T's. So thymoma, you have terrible lymphoma, and you have germ cell tumor. So this you can remember as teratoma. This you can remember as teratoma, and you know Yuvraj Singh had a mediastinal teratoma. Out of these, thymoma is the most common. In middle mediastinum, cystic lesions are more common. You can have pericardial cysts, and there can be lymphomas as well. Superior mediastinum, there can be lymphoma, thyroid tumors and parathyroid, and posterior mediastinum, neurogenic tumors are most common, and neurogenic are the most common in children as well. Most common cause of adrenal incidentaloma. Again, this is a topic, one question from adrenal glands they always ask. Last time it was on pheochromocytoma, this time it is on adrenal incidentaloma. So, adrenal incidentalomas are usually non-functioning adenomas. More than 75% are non-functioning tumors. So, this is from Bailey. Non-functioning are almost 75%, 8% can be Cushing. There can be adrenal metastasis, breast more common than lung, more common than renal, and there can be carcinoma in 2% patients as well. Whenever we encounter an incidentaloma, adrenal incidentaloma, the first thing should be to rule out a functional tumor. And this is the latest flowchart from the new Bailey. If there is a unilateral adrenal mass, you first see if there is radiological suspicion of malignancy. So, radiological suspicion of malignancy, if there is no radiological suspicion of malignancy, we have to see whether it is a functioning tumor or a non-functioning tumor. If it is a functioning tumor, all of them irrespective of the size, you need to do laparoscopic adrenalectomy. If it is not a functioning tumor, no surgery. If there are radiological suspicions of malignancy, is local invasion there? If local invasion is there, do an open adrenalectomy. If there is no local invasion, is the diameter less than equal to 6 centimeters? Yes, we do lap. If no, then we have to decide based on the patient whether to do lap or open adrenalectomy. So, those were the questions from breast, endocrine, thyroid gland. Now, moving on to questions from trauma. Two questions were there. One question was a 25-year-old male who was brought to the casualty after road traffic accident with a pelvic fracture in hypovolemic shock. What is the earliest treatment for control of hemorrhage? So, anyone with a suspected pelvic fracture, this is what we do. We tie a pelvic binder in these patients and we tie a pelvic binder till pelvic fracture has been ruled out. I had covered this in the revision modules as well in the trauma chapter. This same image is there and you can see that even a bed sheet can be tied if you do not have a formal pelvic binder. So, what is the earliest treatment? That is what the examiner is asking. Earliest is you use bed sheets to compress the pelvis. That is the correct answer. Following that, you go for fixations and then you have to do transfusions, right? But first thing, the emergency thing is to use bed sheets to compress the pelvis. Now, there was a question regarding fracture of ribs and a chest x-ray was shown and the history was that the patient has had a fall. Now, what I could gather, I couldn't get the exact chest x-ray, but there was fracture of the 6th and 7th ribs is what students are saying. It was a straightforward image, fracture could be seen, you just had to count the ribs and it was 6th and 7th ribs. So, those were the two questions which were asked from trauma. Moving on to questions from GIT. Now, rectal prolapse has become like a signature of INI-CET. Since the last 3 years, every INI-CET has had a question from rectal prolapse, right? Rectal prolapse surgery. This time was no different. In patients presenting with rectal prolapse, which of the following procedures is not done via the perineal approach? Okay. So, we know Thiersch wiring is perineal. This is perineal because in this we tie a purse string suture. Delorme's repair is perineal. In this we plicate the mucosa and we lift it up, that is Delorme's. And Altemeyer's is also perineal rectosigmoidectomy. Altemeyer's is perineal rectosigmoidectomy because one of the causative factors of prolapse is a redundant sigmoid. Okay. So, Ripstein's rectopexy is an abdominal procedure in which we place a mesh. Okay. Ripstein's is an abdominal procedure. So, partial rectal prolapse or full thickness rectal prolapse, full thickness will have all the layers, partial will just have mucosa. You can see the clinical images of full thickness rectal prolapse, and this is partial rectal prolapse is a mucosal prolapse. Mucosal prolapse in children, the first episode we do digital reposition, and recurrent partial rectal prolapses we do Thiersch wiring or sclerotherapy. Complete rectal prolapse, all the layers are there, and there are two approaches, perineal and abdominal, and I've covered this multiple times that perineal is easy to perform, right, but it has more chances of recurrence but less side effects, whereas abdominal is a challenging surgery, it is difficult to perform, more complications but least recurrence. So depending on the patient profile, we have to choose which surgery to carry out. So if you have a young fit patient, he'll go for abdominal, but if you have a frail elderly patient, it's more likely that they will undergo a perineal procedure. Perineal procedures, Thiersch wiring, this image has also been asked in INI-CET. We take a purse string suture. This is Thiersch wiring. Delorme's repair, I told you, you plicate the mucosa so that it goes up, that is Delorme's repair. Altemeyer's is perineal rectosigmoidectomy. The abdominal procedures are Ripstein's and Wells rectopexy, where we use a mesh, and you can have Goldman-Freiberg procedure as well. So this is mesh rectopexy, where we mobilize the rectum and then we place a mesh between the sacrum and the rectum. One thing which we need to be careful about here, when we are mobilizing the rectum of the sacrum, the sympathetic nerves can be injured. The sympathetic nerves can be injured at the level of the sacral promontory, and if these sympathetic nerves are injured at the level of the sacral promontory, then these patients can develop retrograde ejaculation. This was asked in the NEET exam, NEET PG exam, so you should know this. The same complication can occur in rectal cancer surgery, and it can occur in surgery for rectal prolapse as well. This was a general knowledge kind of a question, where they had said a patient who's undergone lap cholecystectomy, what is the ideal urine output in this patient? Now we know in an adult, the urine output which we want is, minimum output which we want is 0.5 ml per kg per hour. So in a 60 kg man, this will be 30 ml per hour is the minimum. So this can be 0.5 to 1.5 ml per kg per hour is the urine output which we ask for or which we want. That is the correct answer. This was also a very simple question. A patient presents with severe vomiting and diarrhea and has orthostatic hypotension. What are the metabolic abnormalities you would expect in this patient? This is also a pet favorite of INI-CET, right? Usually they ask it as idiopathic hypertrophic pyloric stenosis in a child. This time they had given a 20-year-old male. So that was the only thing which could offset a candidate. Otherwise, everything was related to idiopathic hypertrophic pyloric stenosis, right? If you have pyloric stenosis, there is gastric outlet obstruction, there will be recurrent vomiting. Here also they are saying the same thing. Patient is having recurrent vomiting. So the metabolic changes would be the same. Whenever vomiting is there, HCl is going to be thrown out of the system. And you know the typical metabolic derangement, it is hypokalemic, hypochloremic, metabolic alkalosis with paradoxical aciduria. That is the typical metabolic abnormality which you see. So you have hypokalemia, hypochloremia, metabolic alkalosis, there is no respiratory alkalosis, and in these patients we will prefer Ringer lactate to correct this abnormality. A 73-year-old male presents with painless rectal bleeding. Which of the following below mentioned investigations will be done for this patient? It was a multiple correct answer question. So INI-CET since last 2 exams have started asking these practical situations. That means if you are sitting in the OPD and you encounter such a patient, which all tests will you write in the OPD paper? Right, so those are the kind of questions which they are asking, and that is why internship becomes very important. What you see during your internship, what is the consultant writing after evaluating the symptoms? So those are the kind of questions which they are asking. So here patient is coming with painless rectal bleeding. We will do colonoscopy, that is the investigation of choice, and if there is a mass, we will do biopsy. CECT will be done because there can be certain extraluminal things also which we need to look at. And because in a 73-year-old male, we can suspect cancer. So, we will suspect cancer. There can be diverticulosis, there can be angiodysplasias. These can be the various differentials. So, colonoscopy will help in them, CT will help in them, and CEA, which is a tumor marker for rectal and colorectal cancers, this is also ordered. CA 19-9 is for gallbladder, CBD malignancy or cholangiocarcinomas, or pancreatic cancer. That is the tumor marker for these cancers, and we will not do it in a patient who is coming with painless rectal bleeding. So, again a straightforward question, match the following appendix positions shown in the image. So, they had shown the image directly from Bailey, and they had removed the names, and they just wanted you to match the following. Of course, this is a label diagram, and what they had asked was retrocecal, we know is the most common. Retrocecal means going behind the cecum, you can see behind the cecum. Then they had asked paracecal, which is just hugging the cecum. They had asked pelvic, which is going into the pelvis, it is going into the pelvis medially, and they had asked about subcecal as well. Subcecal is between paracecal and pelvic. The other two are pre-ileal and post-ileal. Post-ileal is the least common position of the appendix. So, again there was a similar question in the NEET PG exam where the answer was hydatid cyst, right, and there were actually two questions. One question answer was hydatid cyst, one question the answer was metronidazole. They had asked about amoebic liver abscess. Here also they asked the same thing. A 25-year-old patient presents with fever and slight weight loss. He gives a history of blood in stools a few weeks back. So, gives a history of dysentery or amoebiasis, and on examination there is right hypochondrial pain and hepatomegaly. Imaging was shown and there was a solitary lesion in the liver, right. So, with a history of dysentery or amoebiasis a few weeks back and now right hypochondrial pain, solitary abscess, you will think about amoebic liver abscesses, and in them the first line treatment is always oral metronidazole, right. So, we have to start metronidazole in these patients. Hydatid cyst, you know, you will either have a floating membrane sign or you can have honeycomb appearance, or this floating membrane is also known as water lily sign. So, these are the various signs, or there can be a calcified hydatid cyst. The history would usually be that it is a farmer. So, those are the things which we need to look out for. Pyogenic liver abscesses are usually multiple, patient will be more sick, and hemangiomas on triple phase CT, you can identify hemangioma, it will have peripheral nodular enhancement. Okay. So, there was a question from inguinal hernias, another unusual question I would say, that they had said that the surgeon reduces the entire hernial sac without reducing the contents in the abdominal cavity. What is this called? So, this is known as reduction in mass, and let me just explain this to you. So, supposing you have a patient who has come with an obstructed hernia, right. Obstructed means the bowel is obstructed inside the hernial sac. So, we know an obstructed hernia becomes irreducible and cuff impulse also goes away. So, normally in an obstructed hernia what you would do is you would open the sac and we can deal with the contents, whatever obstructed or dead contents are there, we can deal with it locally only. But I have given you this example in the marrow videos. I told you that there was an intern of ours who at 3 or 4 o'clock this patient came, and I was a senior resident at that time. I was in the OT, and there was another first year postgraduate who was just catching some sleep, a second year postgraduate also. So, this intern what he did was he sedated the patient and he reduced the hernia. Okay, he forcibly reduced the hernia, and when the postgraduates woke up, he confidently said, "Look sir, there was a patient, I reduced the hernia," and he thought that they will be happy, but they were not, because this was a patient who had obstruction, and now you have pushed the entire sac forcibly into the peritoneal cavity. So, a problem which could be dealt with locally has now become a generalized problem, and you have to do a laparotomy to find that affected portion. So, this is known as hernia a reduction in mass, and that is why any strangulated or obstructed hernia, we should not attempt forceful reduction or taxis, because that can give rise to this condition, that is reduction in mass. Spigelian hernia, you know, is intraparietal hernia. This is a hernia which will stay between the muscle layers, and because it stays between the muscle layers, it is picked up late and strangulation is common in these patients. Madel's hernia is when there is a large defect, and when there is a large defect, you get a W-shaped hernia. So, this is a W-shaped hernia which you are going to get, and in a W-shaped hernia, this is the portion which is intraperitoneal, which can undergo strangulation, and you can miss a strangulation because it is not in the portion which is outside, it is in the intraperitoneal portion. Richter's hernia is when there is a very small defect, and because there is a small defect, strangulation is common. This is commonly seen in paraumbilical hernias. This is seen in paraumbilical hernias, obturator hernias, and femoral hernias. So, strangulation is common, but the initial features are of gastroenteritis, and that is why you can miss a strangulation initially, and these patients will come late. Moving on to the other questions from GIT, you are to identify the abnormality found in the ultrasound image shown below. This was a Phrygian cap deformity. This is another image you can see, Phrygian cap. This is a physiological problem in the gallbladder. I won't call it a problem, a physiological variant I should call it, and this is just a small outpouching in the fundus. This is known as Phrygian cap, and this was a cap which was worn by people in the French Revolution. Nothing is to be done. Phrygian cap doesn't warrant a cholecystectomy. You just have to observe these patients. It's just a normal variation. Mercedes-Benz sign is seen in radio-opaque gallstones. Radio-opaque gallstones, we know radio-opaque gallstones are 10%, and if you get a tri-radiate appearance, that is known as the Mercedes-Benz sign. If it's a biradiate stone, that can be known as a Siegel sign. Gallbladder polyp and gallbladder cancer. So, this I want you to know, gallbladder polyp, you should always know the difference between stones and polyps. So, ultrasound of a stone, you will always see post-acoustic shadowing. So, classical thing which you see is post-acoustic shadowing in an ultrasound when there is a stone, whereas when there is a polyp, you will not see post-acoustic shadowing. You can't see any post-acoustic shadowing here. And a polyp which is more than 1 centimeter, multiple polyps, or polyps in patients who are more than 60 years. So, more than 1 centimeter, multiple, and more than 60 years, those are indications to do a cholecystectomy then. Right. There was another question which was asked, the MRCP image was asked, and which of the following is the most likely diagnosis. So, this was an image of MRCP. We know MRCP is magnetic resonance cholangiopancreatography, and you could see multiple filling defects here. So, multiple filling defects were seen, which is suggestive of choledocholithiasis or CBD stones. We know MRCP is the investigation of choice for CBD stones. So, this we have discussed, Phrygian cap, I have told you these are CBD stones. Another MRCP you can see, another MRCP showing a filling defect, this is a CBD stone. This is an ERCP, right. So, MRCP and ERCP, MRCP is non-invasive, it is for diagnosis. ERCP is endoscopic retrograde cholangiopancreatography. This has also been asked multiple times in the INI-CET exam. This is both diagnostic and therapeutic, but this will not be the first thing which you will do. First, you want to confirm that there are CBD stones by MRCP, then you do an ERCP. Whenever you see an ERCP, you will always see the endoscope, right. You will always see the endoscope. So, that is how you can differentiate whether it is an ERCP or an MRCP. So, to remove choledocholithiasis or to remove CBD stones, we will do ERCP and sphincterotomy to remove the stones. So, these were the questions from GIT which were there. So, which of the following is not true about claudication pain? intermittent claudication pain. So intermittent claudication or vascular claudication, you know, patient gets cramping pain when he walks a certain distance. Now pain of intermittent claudication comes at the first step of walking. This is false. Remember, I've told you an example of 3 patients coming to the OPD. One patient with pain maximum on the first step. This is a patient of osteoarthritis. Second is a patient who gets pain when he bends and he straightens up on change of posture. That is neurogenic claudication. Neurogenic claudication is because of lumbar canal stenosis. And the third patient is the patient who walks a certain distance and gets pain. That is vascular claudication. Rest pain is only seen at night. So some students said this is only seen at night. This is false. Rest pain is more at night. That is correct. So if only was not there, then this is also a correct statement if it was a multiple correct answer question, right? But if they are saying only at night, that is wrong. It is more at night but not only. Most common cause is atheroma. This is true. Atherosclerosis is the most common cause, and the clinical stem does not reflect the site of peripheral arterial obstruction. Nothing of that sort was mentioned, so this is also true. This is also true. So one more thing, maybe students have recalled it wrong. This only term was not there. If that is the case, then this would also be true, and then this would be the only false statement. So I don't know whether it was a single correct or multiple correct. Depending on that, you can choose the correct answer. The site of pain in intermittent claudication is always one level lower than the block, right? One level lower than the block. So this is Boyd's classification for intermittent claudication. This you should know. Class 1 is pain on walking, but pain reduces as the patient continues to walk. Class 2 is pain on walking. Patient continues to walk despite pain. And class 3 is pain forces the patient to stop. Class 4 is pain at rest. The symptoms depending on the site, I told you that pain is always one level lower than the block. Lots and lots of time aortoiliac obstruction, that is Lerick syndrome, has been asked in the exam and INI-CET. In Lerick syndrome, the earliest sign is gluteal claudication or buttock claudication. Femoral and distal pulses will be absent. There is bruit over the aortoiliac region, and there can be impotence in males. This is Lerick syndrome. This has been asked many times. Iliac obstruction, you are going to have pain in the thigh and the calf. Femoropopliteal, pain in the calf. This is the most common, which we usually encounter in the clinics. Now ABPI stands for ankle brachial pressure index. Ankle brachial pressure index, and this ankle brachial pressure index is the maximum value of ankle BP divided by brachial BP. Okay, you get ABPI with that. The normal range is 0.9 to 1.4. These are the values from the latest Bailey. Less than 0.9 is a hemodynamically significant arterial lesion, and less than 0.4 are chronic limb threatening ischemia. CTLI is chronic limb threatening ischemia. A drop in resting ABPI of more than 20% after exercise is indicative of flow limiting arterial disease. So what happens is that in normal people like us, when we start exercising, there's more blood flow in the lower limbs. So ABPI is going to increase. But if there is a patient who has a minor block which is asymptomatic, but when he starts exercising, blood will not proportionately, more blood will not go to the lower limbs. And if more blood does not go to the lower limbs, the exercise, post-exercise ABPI will fall. So post-exercise ABPI is a good test to see those patients who have subclinical disease. Those who don't have clinical symptoms, they can be diagnosed using post-exercise ABPI. This is another Bailey update which I want you to know. This is toe brachial pressure index, TBI. So digital arteries are rarely affected by sclerosis, and TBI in combination with ABPI is a more reliable tool for detecting significant large vessels steno-occlusive disease in patients with diabetes mellitus. Less than 0.6 is suggestive of significant arterial lesion that may have overlooked if ABPI was used in isolation. Very important. We know in patients with diabetes mellitus, those who have calcified vessels, they have high ABPI. They have a falsely high ABPI because of the calcified vessels which are there. Now, if you look at this in isolation, you would think that this patient does not have any peripheral arterial disease. But that is why they are saying that in a patient with diabetes, only ABPI can be misleading. So, look at it along with toe brachial pressure index. If the toe brachial pressure index is less and ABPI is high in a patient with diabetes, that means the patient has arterial disease, and that is what they are trying to say by using toe brachial pressure index in these patients. I hope this is clear. This is an important update for the exam. Right, another question from varicose veins, clinical examination, not the typical question which you expect from vascular surgery, okay. So, patient presents with dull aching pain in both legs, gives a history of prolonged standing and tortuous veins in the legs. Which of the following below mentioned tests are done for saphenofemoral incompetence? So, we know Trendelenburg test, we get to know about saphenofemoral junction incompetence, and we get to know about perforators, Morrissey's cuff impulse is also saphenofemoral junction incompetence, where you make the patient cough. If you feel a thrill at the SFJ, that means it's incompetence. Figan's method is for perforators. Multiple tourniquet test is also for perforators, and Perthes test is for DVT, whether DVT is there or not. So, 1 and 2, A and B are correct statements here. Trendelenburg and Morrissey's can tell us about saphenofemoral junction incompetence. We know that all these tests have a low sensitivity, that is why the investigation of choice is a Doppler. So, I told you Trendelenburg, SFJ incompetence and perforator incompetence. Morrissey's is for SFJ incompetence. Schwartz is another test. We tap over the vein. If there is a thrill, then SFJ is incompetent. Figan's and multiple tourniquet are for perforators, and modified Perthes test is for DVT. Another simple question, which of the following tests is done in patients before performing an AV fistula procedure? Image of the test is shown below. This is Allen's test, and Allen's test is done when we check for two things. So, Allen's test, we get to know about radio-ulnar patency, radial artery, ulnar artery is patent, and also is the anastomosis, the arch between them is patent or not, that we get to know with this Allen's test. Because we want to make a seminofistula for nephrodialysis, renal dialysis is a radiocephalic fistula between the radial artery and the cephalic vein. But I will only make that fistula when I know that the ulnar artery is also patent and the arch is also patent. Otherwise, there can be reduced blood flow to the hand. So, before doing any AV fistula for dialysis patients, we always do the Allen's test. In the Allen's test, what do we do? Allen's test, both radial and ulnar artery are occluded and patient clenches his fist. Then the patient opens his fist and relaxes his or her hand. Then you relieve one at a time. First radial, and you see if the hand is becoming pink. Then you do the procedure again and release the ulnar one and see if the hand is becoming pink or not, right. So, examiner releases pressure and observes how long it takes for the color of the palm to return to normal. Adson's test and elevated arm stress test, these have been asked in thoracic outlet obstruction. There was 3 years back, there was a GIF which was shown in INI-CET of the Roos test, or the elevated arm stress test, right, where the patient was asked, this is the video which was shown, and they had asked what is the name of the test, which condition. So, we do it in thoracic outlet obstruction, and this is known as the elevated arm stress test or Roos test. Adson's test is when you ask the patient to bend towards the same side of the occlusion. The arm should be abducted at 30 degrees and take a deep breath then. And the examiner stands behind and he sees the pulse. If the pulse goes away, that is also a sign of thoracic outlet obstruction. Nicola-Doni or Branham sign. This is also known as Nicola-Doni or Branham sign. This is done in patients with AV fistulae, and in these patients of AV fistulae, if you press the feeding vessel, pulse rate will reduce in these patients, right? Pulse rate reduces, systolic BP is going to increase in these patients, and the thrill will reduce in this patient. Thrill will reduce in this patient. Simple question, they asked you to identify the image. This is a patient with a ranula. Ranula is a swelling in the floor of the mouth. Simple question. Branchial cyst, cystic hygroma are neck swellings which you see in the neck. Cystic hygroma mostly in the posterior triangle of the neck. So ranula we know is a mucus extravasation cyst involving the sublingual salivary gland. It is brilliantly transilluminant, seen in the floor of the mouth. Surgery is either marsupialization or excision of the cyst plus the sublingual gland. We don't do an incision and drainage as it increases the recurrence. These are two questions which have been asked. Most common structure injured is the submandibular gland duct. The most common nerve injured is the lingual nerve while doing this surgery. Plunging ranula, this is a mucus retention cyst involving the sublingual and the submandibular salivary glands. Patient is going to come with a swelling in the oral cavity and in the neck, and the treatment is excision of the intraoral swelling plus aspiration of the neck swelling. So ranula, plunging ranula are also asked many times in the exam. So these were the various questions which were there, which were asked, around 22 to 23 questions. I have divided them topic wise and covered them along with the Bailey updates, which can be potential questions for future exams. Now for those who appeared for this exam and have not fared well, and you want to prepare for November INI-CET, I have some tips for you. Even those who probably didn't appear for this exam but appeared for the NEET exam and are preparing for future exams, these tips are useful for you as well. Look, the first thing which you need to do is that if you have not got a good rank, acceptance has to be there. If you live in a state of denial, you will not improve. So you need to accept that something has gone wrong in my preparation, and then you need to analyze what has gone wrong. So accepting your failure doesn't mean that you're doubting yourself or tagging yourself as a loser. It just means that one is being realistic about things. They know what has gone wrong. Then you need to take responsibility. You can't blame, oh, the circumstances were not right, oh, this did not happen, oh, I had a breakup, or any stupid reason. You can't blame it on that. You have to accept the blame that you could not study well, there was some problem, and now you need to correct it. You need to analyze and learn, write down your mistakes and start working on them, and don't dwell on past failure, right? So failure can either knock you off your game or it can clear your direction and strengthen your mental toughness. It depends on what you do. If you keep on constantly thinking about failure, it will bog you down. You need to think about past success. All of you have become doctors, right? All of you were good students who've done something well to become MBBS doctors. So think about past successes. Think about your success in the NEET UG exam, or think about the success in your college exams. That would motivate you to do well in future. Okay. So failure doesn't come from falling down. Failure comes from not getting up. So if you analyze, accept your mistakes and start working on them, you are bound to succeed. So shift your focus, take a couple of days to analyze and start studying. I've told you, rehearse past successes. Whatever you've done well in the past, think about those things. Procrastinating never helps. Keep yourself away from negative people. Stick to positive friends, family members who can help you during this journey. Don't doubt your abilities. Write down your target somewhere, hide it, right? Or if you are the types who likes to see it every day, write it down and see it every day so that you can work towards it. Communicate with friends and family. Don't alienate yourself from them. Even if your friend has got selected and you've not got selected, don't alienate yourself from them. Still be in touch with them because they can guide you the best. And remind yourself of your goal each day. Okay, so if you do these things, I'm sure you can turn around things in future exams. I wish you all the best. If you have any doubts, please put them in the comment section. I'll be happy to answer them. Or if you want to send a personal message, this is my Instagram ID, Left-Handed Surgeon. You can send me a message there. All the best.